Our next speaker for this series is Dr. Greg Cote, who is the incoming president of CAPER. Greg is a professor of medicine, and he will be talking, he will give us a whirlwind tour of endotherapy and pancreatic disorders. Greg?
Okay, thanks, Walter, and thank you everyone for joining us. For me on the East Coast, this is time to have a glass of wine, which, by the way, one glass of wine is perfectly fine for your pancreas. So I'll be talking about endoscopic therapies in the pancreas tonight. These are my disclosures, since hopefully you'll be getting accreditation for this. So there's a variety of reasons that we're involved as endoscopists, and I'm going to touch on a couple of the key points I think that are most applicable for folks that are seeing patients on a daily basis. So one is acute biliary pancreatitis, or gallstone pancreatitis would be the other common term that you'll see here. We have an important but very specific role in this situation. I'll touch just very briefly on unexplained acute pancreatitis, since this is really a talk in and of itself. And then we have a very important role in treating local complications of pancreatitis, such as pancreatic duct leaks and fluid collections that can develop. And then a really challenging area, which are, but a common one, which are patients that have chronic pancreatitis with pain as being their dominant problem, which is unfortunately the most common presentation with chronic pancreatitis with symptoms. So a very common and extremely important and reversible problem with the pancreas is gallstone pancreatitis. So it's important to remember how this happens. First of all, gallstones typically develop in the gallbladder. And in order to develop gallstone pancreatitis, one or more of those stones needs to come through the cystic duct and get involved in the common bile duct and either impact at the ampulla, and that process of impaction is what triggers the pancreatitis to begin. And many times the patients will actually pass the stone through and actually into their bowel, and it's gone, although the pancreatitis has already taken its course. So the two key features to be keeping in mind when you're trying to diagnose gallstone pancreatitis are that these patients will have gallstones in their gallbladder, and sometimes you have to look fairly hard for them. And they will oftentimes present with elevated liver chemistries, so transaminases, alkaline phosphatase, or bilirubin, or some combination. And we like to see those numbers up more than just a tad, so typically up to 2 to 3-fold above the upper limit of your normal range. So why is this important? Well, because pancreatitis, if it happens once, for most patients it's mild, and like Atur was saying, it will fully resolve and the pancreas will not incur any long-term damage. So with gallstone pancreatitis, this is a very treatable problem. If you remove the gallbladder, especially during that initial hospitalization when the patient presents, they will have a much lower chance of having a readmission with symptoms of their gallstones, with either more pancreatitis or pain or an infected gallbladder. So as you can see here, the patients in blue had their gallbladder taken out during that first hospitalization, and very, very few of them went on to have another event, whereas the ones that were discharged, and they said, well, come back, in a few months, we'll take it out. You can see that many more of them went on to have another event. And that other event could become a severe episode of pancreatitis. So this is critically important really in management. Now the counter to that is that for many, we see a patient with pancreatitis and we feel inclined to remove the gallbladder because we say, well, it must have been gallstones, if alcohol is not the other commonly blamed etiology. But it's important to remember too that if you remove the gallbladder for a patient who has gallstones and has abnormal blood work, their chances of another episode are very low. And if they have just the blood work, just the elevated liver chemistries, or just gallstones in their gallbladder, they also will have a very low chance of going on to develop another episode of pancreatitis. But if they have neither of those and you take the gallbladder out, you can see here that up to 50% or more of them will go on to have more episodes of pancreatitis. And that really fits with the natural history of a patient who has pancreatitis from an unknown cause or some other less and non-reversible cause. So don't feel compelled to take the gallbladder out of every patient, but certainly out of one who develops acute gallstone pancreatitis. Now, the reason I started with the point of how gallstone pancreatitis occurs is because it's not only that you need to remove the gallbladder, you need to make sure that the stone, which must have gotten into the common bile duct, has passed. So how do you do this? Well, if you see it on a transabdominal ultrasound or a CT scan, which are the two most common studies that you'll do in working these patients up, if you see a stone, then you know that it needs to be removed. And that typically is done through an ERCP procedure, so an endoscopic procedure through the mouth. But most of the time, you won't see stones on those two imaging modalities. And so you're left with three other choices. One is for the surgeon at the time of gallbladder surgery to do an intraoperative cholangiogram under X-ray guidance. But few of them are really trained or have the patience to do that now. And so that's why we are called as gastroenterologists to either do an endoscopic ultrasound, which is an internal endoscopic exam. And you can see here the transducer in the duodenum is just a few centimeters away from the common bile duct, and you can clearly see a stone with shadowing behind it. So you can find the stone with great sensitivity in that situation. MRCP is a nice test because it doesn't require sedation unless there's really a refractory claustrophobia. And same thing, it's very, very sensitive for identifying common bile duct stones. So if you find a stone in one of these higher quality studies, then you know that you're obligated not just to take the gallbladder out, but to clear the remaining stone in the common bile duct. Another common question that I'm asked is when a patient presents with acute gallstone pancreatitis, they say, well, you know, you need to do an ERCP and you need to do it like today. So when should we do urgent ERCPs? Urgent ERCP is typically defined as ERCP within the first 24 hours. Now, this is not easy to do. This is what the duodenum looks like in a patient who's in the early phases of acute pancreatitis. You can barely make out the major papilla, which is where the bile duct is draining. And you can barely make that out because of how much edema is in the duodenum. And that's because, again, of the pathophysiology here of how this happens. So we typically only do urgent ERCP when a patient has acute cholangitis. And then afterwards, it's sort of case-by-case selection. I felt compelled to share with you this study, which is just released in Lancet, which is one of the major medical journals. That was a randomized trial that tried to answer this question. It's really the best study to date on this topic, I think, done by several medical centers in the Netherlands. And they tried to answer this question. So they took patients who had acute gallstone pancreatitis, and they looked like they were going to become very sick with their pancreatitis. So they had a lot of inflammatory markers and other markers of severity, such as an Apache 2 score. They did not include patients with infected common bile ducts, so acute cholangitis, because we know that those patients do well with ERCP, so they excluded those. And then what they did was they randomized patients to going ahead and getting an urgent ERCP with a biliary sphincterotomy, where we enlarge the opening with an incision and make sure there are no retained stones in the bile duct, or they're managed conservatively, where they're admitted to the hospital, treated with intravenous fluids, pain control, and monitored to see which direction their course was going. And then, of course, if patients went on to develop cholangitis, or they were found to have common bile duct stones or blockage of their bile duct later, they had the ERCP done later. And so I would say that the conservative group would be the group that is more commonly represented in our practice, and I would say at most major medical centers. And they found what I think most of us would expect, which is that if you look at mortality, which is of course a critically important outcome to most of us, and major complications, there was really no difference between the patients who had urgent ERCP and those that had conservative management. And so that was not shown to make a difference. So it really basically reinforced that we have been doing the right thing. And I just highlighted a couple of other important sub outcomes, such as cholangitis. So of course, if you don't do an ERCP, some of them will go on to develop that, but that's okay. As soon as that happens, then you manage them with ERCP and treat them. If you do urgent ERCP, when they're in that early phase of their illness, you're going to be seeing a lot more intensive care unit admission because of the stress of the anesthesia and just undergoing that procedure when they're already sick. So that's a trade-off of doing it urgently. And then, of course, this reflects this recurrent gallstone pancreatitis. So up to in 9% of patients in this study, this is because the patients were discharged without having their ERCP to clear their bile ducts during that first hospitalization. So again, unless there's a contraindication, if the patient's too sick or there's simply too much swelling that is still present, you really want to make sure you take care of the biliary issues. I can't emphasize that enough. And their cannulation, their access rate was actually very low, only 80%. And that again speaks to the fact that These are very difficult cases to do when you do them in the urgent setting. So it is okay to back off and be conservative, and we have hot off the press data to justify that. Now, there's also another role for the endoscopist in doing endoscopic ultrasound or MRI. When you have a patient that has pancreatitis, but you can't figure out what it is that's causing it. You've taken a history, they don't have a history of high intake of alcohol, medications, other known risk factors for developing acute pancreatitis. There's a role for doing one of these two higher quality imaging studies to look for some of these more subtle findings. One of them, again, can be small gallstones that are missed on a transabdominal ultrasound. You will sometimes find pancreatic cancers, pancreatic cystic neoplasms, chronic pancreatitis, so a stricture in the pancreatic duct that may have triggered their episode, and even autoimmune pancreatitis, which is a rare condition with a pretty classic MRI features. You can sometimes find main duct IPMN, which is a mucus secreting condition of the pancreatic duct and also a precancerous condition. And then some anatomic variants such as Pancreas Division and ampullary processes. So ampullary adenomas, choledochal seals, which is a cystic dilation at the bottom of the duct, and sometimes duodenal pathology like a duodenal cancer or a large peptic ulcer. So what about ERCP? I haven't really talked about that. ERCP is, again, an endoscopic procedure where under X-ray we actually enter the ducts. And in the old days, it was really the only diagnostic test, but now it's really become almost entirely a therapeutic intervention. So when we know that there's pathology, we use ERCP to help to treat it. And really what ERCP is good at finding is, quote, obstructive etiologies. So Pancreas Division is one entity that has been brought up. Sphincter of Oddi dysfunction. These are both controversial factors that may be contributive to causing pancreatitis. And then some rare congenital abnormalities, which I'll highlight in the next slide. Now, there are two studies I want to draw your attention to. One is called the SHARP trial, where we're studying Pancreas Division and the role of endoscopic treatment. There's centers all across the country that are participating in this. And so you can go to pancreasdivision.com and find out more about that. And we're also doing a longitudinal cohort study at many centers also across the country with some overlap between the two, where we're performing ERCP with some of these more controversial indications and then following patients very carefully to see who goes on to develop pancreatitis in follow-up and other important patient-centered outcomes like pain and quality of life. As I mentioned, there are some rare things that you'll find on ERCP which could be missed on an MRCP or an endoscopic ultrasound, and here are a few examples. So one is an anomalous pancreatobiliary union. So again, during development, when the pancreas fuses, sometimes the pancreatic duct fuses into the common bile duct, but upstream of the opening of the ducts to the intestine. And so what happens here is you have mixture of bile and pancreatic juice, and this is undoubtedly a risk factor for both pancreatitis as well as cancers particularly of the bile duct. So this is something that you'll want to identify early and treat. And this is not something that's only identified in children. Sometimes this will only present in adults. We've talked already about Pancreas Division, but this is, again, failure of fusion of the pancreatic duct to the ventral duct, and so it drains separately. And you'll sometimes find that on ERCP after, despite having high quality MR studies before. Main duct IPMN is shown here. So this is the pancreatic duct. It's larger than what would be considered normal. And as you follow it down, you can see that there's a filling defect here, which doesn't look like a stone. It sort of fits with the contour of the duct. And what that is it's a large ball of mucus. And because of the fact that it's close to being fluid density, it can be missed on an MRCP. So we will sometimes find these on ERCP, but generally speaking, because of the risks of that procedure, it's not recommended except for extenuating circumstances. So as I mentioned, we have a variety of tools that we can use as endoscopists to treat a series of problems related to pancreatitis, complications. So sometimes the pancreatic duct will be disconnected and therefore leak pancreatic juice into the retroperitoneum. Sometimes we will see patients that develop large pseudocysts or even walled off necrosis and biliary obstruction from the scar tissue or the inflammation. These are clear indications for us to help out. So we are good at placing stents and draining fluid collections and even draining necrotic collections through the stomach or duodenal wall. There's some other areas that we serve a role, but the role is a little bit controversial, and that's in treating patients who have painful chronic pancreatitis with what we call duct obstruction. And then sometimes when the duct is completely fractured and there's a section of pancreas that's not draining in continuity, we can sometimes manage that with stents. And then there are some much more complicated patients that have what we call small duct chronic pancreatitis, where there's no clear problem in the main duct, but they have lots of pain and scar tissue, and we will sometimes help them with celiac-guided nerve blocks. So the tools of the trade are fairly limited, and they haven't changed a whole lot, unfortunately, over the years, but they include sphincterotomy, which is the performance of an incision on the opening of the duct. And what this does is it allows us to advance larger tools into the pancreatic duct or bile duct to implement therapies. It also, in theory, helps with juice drainage. And so for patients that have problems with scar tissue right at the opening, by cutting the sphincter, we may be able to treat a cause for their pancreatitis or their pain. We can place stents, which are simply drainage tubes. And so this is helpful for patients that have a blocked duct or an obstructing stone that can't be removed at that time. And then to remove actual stones. Now, pancreatic stones are, no pun intended, hard as rocks. So they're very, very hard. You can try to throw them against the floor, a concrete floor, and you will not break these things. You need to use much stronger force than that. And so as a result of that, we have a variety of more sophisticated instruments that include electrohydraulic lithotripsy, laser lithotripsy, baskets, and even extracorporeal shockwave lithotripsy. And so depending on the patient, we'll use one or more of these modalities. The challenges with the mechanisms of pain in chronic pancreatitis, there really are many. So I talked about pseudocysts and necrosis. A lot of the mechanisms of pain are probably low-grade inflammation, including inflammation around the nerves, going into the pancreas and feeding nerve pain signals back to the spinal cord, mechanical problems like duodenal and bile duct obstruction, and pancreatic duct obstruction. And this is the one that we're often called on to treat when we find stones in the duct such as this. So really our job is to try to treat what's the so-called pancreatic duct hypertension, or high pressures in the duct. So here's a patient who has an obstructing stone, and you can see a large pancreatic duct, but there's not a lot of pancreas around it. So this is a stone that has probably been present for many, many years. Whereas to the left, to the right of that, you have another stone in the same location. This person has a lot more viable pancreas behind it. And so unfortunately, we're not very good at looking at a patient and saying, well, when is the pancreatic duct really the source of pain? We can't characterize the quality of the pain and tie that to the mechanism. And so we're really left with our best judgment in talking with the patient and giving them the pros and the cons of our approach versus a surgical approach, which you'll hear about in a few weeks with Dr. Morgan. But it really comes down to that and just looking at the pancreas. So here's a pancreas that is really riddled with calcifications and stones. So not as much enthusiasm for someone like myself. Then you have the isolated stone here. This is something that's a little bit more enticing. Another isolated stone, but now this is deeper and farther from the intestinal wall, so a little bit more challenging for us to reach and to remove. And then you have a patient here that has very little visible pancreas, so a lot of fatty infiltration in it, and no evidence of main duct pathology. All of these patients may have pain, and we're really trying to determine which of these patients will do the best with endoscopic treatment. And we're just not very good at it, at predicting endoscopic therapy in terms of pain relief. So really what we do is, unfortunately, we end up, after discussing the treatment option with the patient, we hopefully will explain to them very carefully that they may or may not get better. And then we embark upon endoscopic treatment. And for those that don't get better, we seek alternative treatment pathways. So it's a bit of an empiric approach at this point, which is unfortunate. And this is shown here. These are all the randomized trials that compared a variety of interventions, mostly surgery, to endoscopic therapy. And what I've highlighted here are the patients that experience complete pain relief with endoscopic treatments. And you can see at best, it's a 50-50 shot. So that's not very good. We obviously need to do better than that. Again, I wanted to make sure you were aware of the most recent and I think highest quality study to date on this topic of endoscopic treatment. So this was a randomized trial where endoscopy was compared with surgical treatment options, which again, you'll hear about in a later lecture. And what they did was, again, they randomized to one of these two groups and then followed them going forward. In the interest of time, I won't go through the actual interventions, but both the surgical intervention and the endoscopic intervention were what we would consider to be standard of care for either approach, and very thoughtful and aggressive. So doing our best to treat the pancreatic duct problem. And what you can see here is this is pain, the pain scores on the y-axis. And you can see that in the endoscopy group, they did get some better, but they're still having pain scores of 40 out of 100, which is a fair amount of pain for these patients. And even with surgical therapy, you can see they're a bit better, but only marginal. And so the goal is to get that pain score down below 10 or even 0. And you can see that both approaches have a lot of room for improvement. So why should we consider endoscopic treatments at this point? Well, first of all, there's just not a lot of other great options at this point. We don't have any other great treatments besides surgery, which patients understandably are reluctant to have, especially up front. Surgery itself is more morbid, so it's more invasive than what we do. And many of these patients also have underlying medical comorbidities that preclude surgery. And when we embark upon endoscopic treatments like stents and stone extractions, it doesn't typically preclude surgery as a follow-up step. So it's kind of like a step-up approach, so to speak, for these patients. And so many do prefer that type of approach rather than a surgical approach first. The best factors that we know of now in terms of what will predict response from the patient standpoint, if the patient has a relatively short disease duration. So this is why it's important to diagnose chronic pancreatitis early and to start to embark on some of these sophisticated treatments and not to wait until their pain becomes a central pain where their brain has been reprogrammed and it's very hard to treat the pain at that point. When they have less frequent pain attacks, and if they are compliant with quitting smoking and alcohol, for those that are exposed to those interventions, both of them, smoking and alcohol, both need to be discontinued completely. I really try to harp on that with patients, especially the smoking, because everyone focuses on alcohol, but really they're equal co-conspirators in causing pancreatitis. And then as far as structural features, I've kind of touched on this, but for the calcifications that are in the head of the pancreas, those are the best cases for endoscopic treatment. When you have lots of calcium burden, it's much more difficult. So as a general rule of thumb, our guidelines would suggest that if they have small stones, ERCP is a reasonable first approach. But as the stones get larger, we're not as good at being able to remove these without breaking them into smaller pieces. And so then our guidelines would recommend doing some form of lithotripsy first to make them into smaller stones and then extract them if they don't flow out of the duct on their own. Now, if they just have strictures, so scarred blockages of the pancreatic duct, endoscopic therapy is sort of, you're marrying the patient for at least a year where you're bringing them back many times, 3 to 4 or more times to be replacing stents to enlarge or stretch that duct and hope that it forms a cast around the pancreatic duct. But bear in mind that all of this is really based on moderate to low quality evidence. So for those that are in smaller medical centers, it's a good idea to engage a pancreatic center of excellence to help you with this. There's a lot of pain it's so complicated, and I by no means consider myself to be an expert on this, but it's not as simple as there's a stone, that's the cause for their pain, we take the stone out. There's a variety of other factors that stem from genetics to functional brain processing issues, past experiences. So there's a lot of mechanisms that play into this, and it really takes a team to manage the patient's pain, not just a gastroenterologist. I just want to alert you also to that we're trying to study this a little bit more rigorously. So we're actually starting a sham endoscopic trial for patients with painful chronic pancreatitis with the hopes that this will provide us with the necessary preliminary data to do something on a larger and more national scale so that we do a better job of finding the right patients to offer this intensive intervention program with endoscopy. So where do we go from here? Well, we need to do a better job with phenotyping pain, not just asking them what's your pain score from 0 to 10 or 0 to 100. We need better pain biomarkers so we can do blood tests to characterize the type of pain that a person has. There's a lot of interest in what's called quantitative sensory testing to help determine the origins of their pain neurologically. And then we also need better tools in endoscopy to do a better job of opening strictures, of removing stones, not having to bring patients back by using biodegradable stents that will just be absorbed or secreted by the body over time so that the interventions are less cumbersome. And I will stop there.
Thank you, Greg. And again, thank you, Artur, for these whirlwind tours. We are running a little bit behind time, but there are a few questions. We'll try to get to them. So Greg, your discussion on gallstone pancreatitis generated a few questions, particularly how many % of patients with gallstone pancreas do not have any perturbations of liver function test abnormalities? As a corollary, in these patients with gallstone pancreatitis, how often does the dilation of the CBD, what does that rule in or rule out for you in regards to stone sludge management without clear cholangitis?
That's a good question. So I don't have a precise answer for you on the liver chemistry question, but I would estimate roughly a third to a half as many may not have twofold to threefold elevation in their liver tests. A lot of it depends on when they present. So these are things that will go up for a short period of time and then normalize. So that's why you really want to use the combination of the gallstones in the gallbladder and the labs to help you make that judgment. Duct dilation is a good indication of either a retained stone or a recently passed stone, but it's also not a perfect marker. So generally speaking, we use 8 millimeters for a person who has an intact gallbladder, 10 millimeters for one whose gallbladder has been removed, but there's an age factor associated with that and opioid use and so on that can play a role as well.
Great. And another comment about ESWAL, you kind of briefly touched upon that with those stones. One of the challenges with ESWAL is access, right? It's not often done. Very few centers will do it. Urologists have predominantly done in the past. Are there examples of gastroenterologists doing ESWAL, and what about other lithotripsy methods, I suppose, or how do we get around that? What is your take on that?
Yeah, so we had a relationship with our urologists and became frustrated by it because they treated pancreatic stones like kidney stones, which are not composed of the same material. You need to be much more aggressive with the intensity of your treatment and so on. And of course, they don't know anything about pancreatitis, like I don't know anything about pyelonephritis. So we've taken that over. It is time consuming, but it's not technically complex. There are other approaches where you can actually enter the duct using a pancreatoscope and perform lithotripsy in that manner, but the current devices for that are 11 to 12 French, and so it's a very selected subgroup where you can technically achieve that direct visualization and perform essentially the same technology or use lasers to break the stones up. But I don't think it's as generalizable as extracorporeal shockwave lithotripsy for pancreatic stones. So I think it's a matter of either develop a working relationship with your urologist, who probably use it at least to some extent, or seek out training in it, which again is not very complicated. And there are industry representatives that can bring the equipment to your hospital facility, and you can do it for a couple days a month type of thing, depending on your needs, because the equipment itself, your hospital may not actually own it.
Got it. You talked about the value and the potential for endotherapy to treat painful chronic pancreatitis, and you have a clinical trial. You mentioned you kind of pointed out how there's a stone with atrophy, so that stone's been there, and then you mentioned a stone with essentially normal tissue. What is your opinion about intervening on a stone in the head when there's plenty of tissue up in the body and tail? Do you believe removing that stone, even though if the patient's not having pain, will have benefit in minimizing atrophy?
That's a great question that I don't have the answer for. I don't know. I think I try to factor in a number of things, including the patient's age, of course, and expected life and so on. But if it were easy to remove, then there would be little debate. But you can oftentimes, so to speak, poke the bear. Don't mess with the pancreas is the old adage, right? And so you can it's very hard to take an asymptomatic patient and make them better. So it usually requires a very, very careful discussion. In my younger days, I was much more aggressive. I have to say, as I've gotten older, I've become more conservative because I've gotten myself into trouble. When You start to, because once you start, you have to finish, because once you place stents and so on, you've now contaminated the pancreatic duct. You need to clear that stone out. We don't have a good answer for that though, in terms of the natural history for a non-diabetic who has no exocrine insufficiency, et cetera.
Okay. Artur, you caught my attention when you mentioned, maybe I misheard this, but you mentioned that the islets tend to be more prominent in the tail. Could you talk a little bit more about that? I just assumed that they were homogeneously spread from head to tail.
In development, for some reason, the pancreatic islets themselves are really predominantly associated in the tail. And interesting enough, your neuroendocrine microadenomas and neuroendocrine tumors typically or more often arise in the tail than they do in the head as well, just based on location. Interesting, I don't know why. They are certainly well vascularized, and so that doesn't seem to inhibit, or at least the distribution doesn't seem to inhibit or induce any changes in glucose homeostasis. But certainly that it's just an oddity or just a fact of development that the islets tend to be more prominent there than in the head or body of the pancreas itself.
That's interesting. Can you talk briefly a little bit more about the significance of fatty pancreas? You mentioned it kind of uniquely, kind of seen pathologically in hereditary pancreatitis, but what should we be thinking about for the clinicians when we see imaging of fatty pancreas? How do you think about it as a pathologist?
Yeah, that's a very good question. I mean, one of the problems, again, is the pancreas is not an encapsulated organ, so it really blends in with the retroperitoneal fat. And to the pathologist, when we get a resection, let's say, of the pancreas that's very fatty, it's really what we call lipomatous atrophy of the pancreas, where you see involution of the pancreatic parenchyma, and all that surrounding retroperitoneal fat just kind of takes over what used to be the pancreas. And so when we see in hereditary pancreatitis, like PRSS1 associated or even CFTR associated pancreatitis, typically what happens is, for some reason, that induction of fibrosis is not characteristic of those patients. But the reality is that that retroperitoneal fat just kind of ingrowths and just takes in the space that the pancreas used to be. That being said, the pancreas tends to look very waxy and fatty and oily when it's resected out of these patients, interesting enough, which really just recapitulates what we see with that fatty pancreas.
Yeah, I think a lot of attention has been brought to bear on that with our imaging, and we're seeing a lot more fatty pancreas, like we're seeing fatty liver, and it's raised an interesting, another potential disease syndrome, but it's a very complicated story because, as you kind of articulated. So, so I think that we'll wrap things up. I know Mason had a comment just, and it wasn't a question, and Artur, for your talk on highlighting all the different congenital anomalies. You know, raising the awareness as a clinician, just because these anomalies exist do not necessarily mean we need to do something about it. And we'll perhaps hear more about that at our next series of conversations. And again, thank you for kind of laying the groundwork, Artur. And Greg, thank you for kind of kicking it off with some clinical relevant material that generated a lot of questions. To the audience, thanks again for participating. There's 5 more webinars, and next week we'll have Chris Forsmark talking about giving us an overview of chronic pancreatitis, followed by Mark Lowe, who'll be talking about unique aspects of pediatric pancreatitis. So thank you very much. This video webinar will be posted, and so you'll be able to access this if you were not able to get it, or you'd like to see it again. Some people have asked about whether the presentation slides will be available, and we'll look into that, but you will be able to see these, access the whole video and the recording afterwards. Thank you. Have a good evening.
Thanks, Walter.
Thank you.